However, you're absolutely right. There are now a lot of advanced molecular tests are done, which can correctly identify the disease and also tell us if there is a druggable target. Now we have, as you know, you have heard magic bullet for cancer. So there are some cancers which have a certain mutation which can be targeted with a drug.
Okay.
So that sort of improves the outcome and reduces the side effects. So we also do those molecular tests for certain cancers. It helps us to also do what is called risk and response stratification to look for minimal residual disease. These are all the, the new things that are happening. And we have access to this in India routinely.
So if we look at leukemias, how are they treated? I mean, if I understand, it's primarily a treatment which is done is chemotherapy. And how effective is the treatment? How long is the treatment?
So let's talk about the common leukemia in children, the acute lymphoblastic leukemia, which we commonly call ALL. Right? Treatment is mainly chemotherapy based. Treatment is prolonged. It is about 2.5 years of treatment. The initial 6 to 8 months treatment is quite intensive. And during that period, we advise a lot of precautions because these drugs cause immunosuppression. So we don't want the children to be catching infections during the treatment period. So things like personal hygiene, food hygiene, then treatment discipline, strict compliance to treatment. Because as you know, cancer cells are rapidly growing. Because they are rapidly growing, they are prone to mutations. If they don't get their drugs on time, mutation can be one that causing drug resistance and therefore more chance of relapse. So we have to be absolutely disciplined in our treatment. And the outcome for ALL, as I've said, 70 to 90% long-term cure rate. So it's worthwhile putting that much energy and effort into taking the treatment properly with all the precautions.
Right. It's a long drawn treatment as we understand. I mean, 2.5 years. What about the cost issues involved in this entire treatment protocol?
So yes, it is a complex treatment and it is expensive. And I will say that the cost of treatment includes not only just the chemotherapy cost, but also the cost for supportive care, management of infections, requirement of blood products, red cell transfusions, platelet transfusion. And then there are other components of treatment which require multidisciplinary care. For example, the nutritionist, the child psychologist, because the treatment is 2.5 years, we have to ensure these children with their studies, they don't get emotionally depressed. So we have counselors involved very closely with the treatment. We have the dietitian very closely involved. We want them to maintain their nutrition because as you know, these drugs do cause mucositis. They do cause lack of appetite. We have to be always raising their weights and ensuring that their diet is well maintained.
So when we look at the outcomes, I mean, you told us it's got an excellent outcome. So if we compare a developed and a developing country, developing nations, are we at par with the developed countries? Are our drugs, the treatment protocols that we follow is something which the West also follows?
So the drugs are more or less, so the first line treatment for ALL, which cures 70 to 80% children, those drugs are as well available in India as they are anywhere for the first line. The difference is mainly in the infrastructure. By infrastructure, I mean also the infections and the nutritional status of our children. So this is important. They have fewer infections. The developed countries, the children by and large will be healthier and they would be having less infections. Some of our children come with very advanced disease. So these 2 or 3 factors would definitely affect the outcome. Then the second thing which would be different is the relapse patients or the very high risk patients. Those would be having better options for treatment in the developed world. But for the first line, we have all the drugs. We have all the drugs, we have all the facilities. The treatment here would be as good as anywhere else.
Oh, that's a good news. So people don't have to run to the US or to the West to have their treatments done. So if we look at younger children, do they fare better than the young adults and the adolescents?
You know, Tapaswini, like for all cancers, we have what is called risk stratification.
Okay.
So whether it's leukemia, solid tumor, or a lymphoma, in all of them, we risk stratify. The purpose of risk stratification is, if this is low risk or favorable risk, let's give lighter treatment. And if this is high risk or unfavorable, let's give stronger treatment.
So any role of radiation for these patients? If we look at leukemias, is there any role of radiotherapy?
So radiation is a very effective treatment for cancers, generally speaking. For acute lymphoblastic leukemia, we have a part or component of treatment which is called cranial prophylaxis.
Okay.
So the CNS or central nervous system is a sanctuary site for leukemia. To prevent it, maybe 30, 40 years ago, we used to do cranial radiation for everyone. But due to the late effects of cranial radiation, we now do only intrathecal. So in the leukemias, the role is somewhat limited. But for the pediatric solid tumors, for the brain tumors, radiation is a very, very effective treatment modality. In fact, I would like to say that cancer treatment in children is multidisciplinary, and there is a very important role of the radiation oncologist and the pediatric surgical oncologist in the treatment. And there is a certain time and sequence at which these treatments must be delivered so as to ensure optimum outcome. So it's not chemo alone, it's our radiation colleagues, our surgical colleagues, which have an important role. However, the pediatric oncologist would be coordinating all these activities. More so because chemotherapy is the backbone of most of the childhood cancers.
Correct. Right.
And the surgical and radiation treatments would be sort of local therapy strategies.
So in situations where there is relapse or the child fails, has a recurrence, where does the role of bone marrow transplant or the stem cell transplant come in?
Stem cell transplant, as you know, we call it hematopoietic stem cell transplant.
Correct.
We used to call it BMT in the days. Now we know that from the marrow, we get the hematopoietic stem cells. Now, the BMT has a role for high-risk leukemias. It also has a role for multiply relapsed diseases, which are chemotherapy sensitive.
Okay.
The main thing is that the disease, whether it's a leukemia, it's a lymphoma, or it's a solid tumor like neuroblastoma, the disease has to be chemotherapy sensitive. So what we do is we give high-dose chemotherapy.
Right.
But because high-dose chemotherapy would cause severe myeloablation, so we try to give transplant and have the donor cells which can rescue the child.
Okay.
If the disease is in the bone marrow, we ablate the marrow and then try to get healthy marrow, because the disease should not come back over there. So there is an allogenic transplant and there is an autologous transplant. The allogenic is when you have a donor who is someone other than the patient, who is HLA matched, and where the disease is in the bone marrow. While the autologous transplant is for a solid tumor where the marrow is actually healthy. You take the child's own marrow, cryopreserve it, give high chemo, and then give back their own stem cells to rescue the marrow suppression. So there are two types. It's a very successful treatment today. Many centers in India are doing transplant in children, and importantly, the success rates are very good now, because the treatment strategies have become very fine-tuned and very advanced, and even here in India today.
That's really very, very nice and a good news to hear. Ma'am, you've been into this treatment of children for so many years. It'll be lovely if you can share some inspiring stories, some touching, heart-touching survival story.
As a pediatric oncologist, our job doesn't end with the end of treatment. I will say that now for the cancer survivor, particularly if this is a child, we must follow with them. So for a couple of years to make sure they don't relapse, but subsequently to ensure that they are having productive lives. We ensure education. We try to counsel them because many of them have fears. Yeah, many of them are depressed. They are not sure about themselves. So in that way, what we have done is we have formed an after completion of therapy clinic, which we hold once or twice a week here. And we also now have a survivors group. It's a group by the survivors for the childhood cancer patients. It's called Ashaएं. So we have about 100 children who are now in the group. Basically, they have a newsletter to motivate each other, because there are issues with marriage, there are issues with jobs. There are people who don't give jobs if they know your history. There are people who don't give you insurance. So these are issues for them. There are stories, which would be stemming from children coming from the remote villages. Now we have a little guest house here, which is by one of our parents. It's called Grace, where they keep them free for 6 months. Because for 6 months, they have an intensive treatment. They can't go home. They don't have a place to live. So they have got very clean lodgings for them. We discussed earlier, the treatment is expensive. So we also have many NGOs with us. Rajiv Gandhi also now has a philanthropy department which tries to help children it's a curable cancer. It's worth putting the effort and getting the donation. So I will say that almost half of our children, they are on some financial support. And of course, everybody gets emotional support and everybody gets psychological and nutrition support.
Wonderful.
There are many stories.
Before we conclude, let's clarify certain myths with respect to these cancers. One, survivors have short lives. Is it true?
So when we say 5-year survival is 80%, it doesn't mean that they will only survive for 5 years. It means that if they have survived 5 years, risk of relapse is negligible and they will be long-term survivors. So they should live another 50 years.
The second is survivors are disease carriers and pose health risk to others. How correct is the statement?
Absolutely not. This is a total myth. Cancer per se, as we know, is not infectious. It doesn't spread from one to the other, and it doesn't run in families. So if a child has survived cancer and he is cured or she is cured, then it does not mean that their children have a higher risk of cancer. It's no such thing. It does not actually transmit to their children. So it is absolutely a myth. They are not carriers. Cancer, not a hereditary disease.
Third is all survivors are genetically inferior and have fertility issues.
Absolutely no. They are not genetically inferior. However, certain treatments would have an impact on fertility. So certain alkylating agents, they do have an impact. The current treatment strategies, they try to reduce the cumulative dose of these drugs so that spermatogenesis is not affected. And in some of the older adolescents, we would actually do sperm preservation as well. But if you look at broadly, or if we say that cancer survivors are infertile, that would be totally untrue. I have many survivors who are married and who have normal, healthy children.
The fourth is childhood cancer survivors can never have a normal life.
That is untrue. But there is a big social stigma in the society.
Right.
And so because of that, so there is need for advocacy. There is a need to spread the word that this is not genetic. They are as good as the next person.
And the other is survivors do poorly in school and have some issues in future job placements.
Yes. So usually survivors don't have issues with schooling and they are good at their jobs. However, there is a social stigma and certain people try to not give them, they have these prejudices against survivors or with the word cancer is scary to most people. There's a big need in our society to sort of encourage these children who have had such a tough life and to give them opportunities which they deserve as per their capabilities. We should not judge them by their past medical history.
Right. Thank you so much, Dr. Gauri. Thank you so much. And this beautiful smile of yours and that magical touch of your hands, may it continue to bring happiness and joys in the lives of many, many, many more children that you're going to treat. And thank you all the listeners. See you next week with another expert on a different cancer. Till then, goodbye.